think it's really important that we talk about exercise therapy in regards to helping a diabetic better control his blood glucose. I mean, as we know from previous systems, there are so many benefits to exercise, not only for the diabetic, but for anyone. Really has quite an effect on a diabetic's blood glucose. And this should really be part of a diabetic treatment plan. It's not always necessary that before a person begin to exercise that they are automatically screened to make sure that the patient will remain safe during their exercise activity. We've heard, that probably walking is the best type of exercise. It doesn't require a gym membership. It's quite inexpensive. All people really need to do is have a good pair of walking shoes, and that's basically all. And just to keep moving and get their, heart rates up, and hopefully, gradually increase their time so they could really build up their cardiovascular health and really minimize some of these complications that may occur from diabetes, as well as keeping their blood glucose within a very safe and acceptable range. Many of our patients that do get diagnosed with diabetes, particularly our type 2s, and that really have no manifestations of any cardiovascular disease, anytime a person is involved in exercise, it does put them at risk for injury or even some life-threatening cardiovascular event. Now remember, many of our patients are very complex. They have previous health problems. Maybe they're on blood pressure medications. Maybe they're on medications to help bring down their cholesterol levels. And maybe some of them can also be on antiplatelet medications or medications that affect their clotting time. So you need to keep this in consideration, because anyone who falls could be at risk for serious injuries, especially if their blood pressures are too low, or if they fall and cut themselves or have an internal bleed. That bleed could be far more extensive because maybe they're on Coumadin or aspirin or some other medication, maybe because they're have had a previous MI, or they've had are in atrial fib or some kind of that situation. That's why walking seems to be almost the safest type of exercise rather than vigorous aerobic activity. Not that that's not good, but sometimes that will predispose someone to having more of an increased risk for falls. You would probably screen somebody before they begin exercise if they've had a history of chest pain or just discomfort. Maybe they do have a history of angina, and you want to just see to what extent they should push themselves. Somebody that might have an abnormal EKG, which might show some kind of ischemia, any type of carotid or peripheral vascular disease. People that are older than 35 that really just sit around and really have not done any kind of physical activity could be at risk for injuring themselves, or maybe have underlying, cardiac or blood pressure problems, which probably be a good idea to check them out before they start doing any kind of vigorous exercise. Even some of the ones that have been diabetics for a long time that really wants to start getting back in shape, that might have some neuropathies or might have some vision problems or things like that, or might be at risk for stroke. You just want to make sure that the activity or the exercise that they do will not enhance or aggravate any more serious complications. Lifting heavy weights, things like that might increase blood pressure or put a little bit more stress on the vasculature. So these are things that you just kind of want to explain to your patient. I mean, somebody that hasn't exercised in years and years, and then says, I want to go out and run a 5K or a 10K, that would be a little bit dangerous, especially if they have not done any whatsoever type of exercise. If people also have cardiovascular risk factors, that's probably also a good idea to kind of screen them before they begin exercising. And a great thing to do to assess for any cardiovascular disease is to do a treadmill testing to determine if a person can, get to that target rate without any serious ischemic changes or changes to their EKG. So these are things that, we want to just consider before we get people exercising. We want to keep them safe, and we don't want to create any more situations down the road. The recommendation for exercise is about 150 minutes a week. Helps to increase physical fitness, helps to improve their emotional state, and really for those diabetics that are trying to lose weight, it also helps with weight control. Exercise also increases uptake of glucose by muscle cells and really helps to very often bring down cholesterol levels and also decrease the risk of cardiovascular disease. And, not many people always like to exercise, so you want to really encourage your patients or even yourself to find an exercise that you're going to enjoy, that you're going to want to do. Because if you hate to run, don't start running. If you don't like to swim, don't start swimming. That's why it's important that people wear proper footwear, and the rule of thumb for your feet is to inspect them every day, because sometimes if neuropathies are there, you may not feel that there's an injury, and you want to catch that right away so you can seek medical attention. If there's a callus or an injury or a blister, if you don't inspect it, you won't see it, because maybe at times you won't be able to feel it. Avoid any extreme hot or cold. Don't go out in the middle of the day and exercise when it's 95 degrees outside, and the same goes for in the winter time. Avoid exercise during periods of poor glucose control. That's why it's always important that before you exercise that you really check your blood glucose. Where are you at? If you're kind of nearing low normal, that's where it's really important that you carry around that fast-acting carbohydrate to prevent any signs and symptoms of hypoglycemia. Type 1 diabetics really should exercise in regards to the timing of their exercise in relation to meals and insulin injections and the time of day of the activity. They sure wouldn't want to exercise during their peak time of their insulin. Moderate and regular, brief, intense exercise tends to cause a little bit of mild hyperglycemia and prolonged hypoglycemia. So that's why it's important that they don't exercise at peak insulin actions, because that's where hypoglycemia can occur. Obviously, monitoring blood glucose before and after, maybe before a little bit, a slight snack to keep those blood sugars increased, because with exercise it may bring down blood sugars maybe too low. A quick carbohydrate source 1 hour, maybe after exercise. Usually when a person completes exercise, blood glucose falls to normal after the first 60 to 90 minutes. You want to make sure, though, with your type 1s that before they really begin exercising, that they really achieve some kind of glucose control, because like I said before, that's where they're going to have problems with hyper or hypoglycemia. With your type 2s, obviously weight loss is a great benefit from exercise. And like I said, some of these patients may require some medical screening. And then, of course, along with the aerobic exercise, resistance training may be also a great type of exercise. to improve cardiovascular stamina. There's a lot of benefits to exercise, as I said before. Sometimes the benefits of exercise last to bring down triglycerides and cholesterol 72 hours after exercise. Systolic blood pressure, also benefits even 12 hours after exercise. It's really important that before exercise that you encourage people to warm up, stretch, and then cool down about 5 to 10 minutes after the completion of your exercise routine. Along with exercise, we talk about hypo and hypoglycemia. It's also important that during exercise a person stay well hydrated, because we don't want any episodes of dehydration to occur. And the American Diabetic Association recommends that there be no more than 2 consecutive days without any aerobic physical activity. So we really like you to not go longer than 2 days without exercise. Remember, if blood glucose is elevated, we want to check urine for ketones. And if they're present, we would not recommend that the person exercise, because this really just proves that there is very poor glucose control. Your book really does provide a nice chart to educate patients about self-management during exercise. Wearing appropriate footwear, reinforcing the level of exercise recommended for that patient based on his or her physical health, examining their feet daily and after exercising, proper hydration, really warn the patient not to exercise within 1 hour of insulin injection or near the time of peak insulin action. And do not exercise unless blood glucose levels are at least 80 and less than 250 milligrams per deciliter. And always carry a simple sugar to eat during exercise if symptoms of hypoglycemia occur. Those early signs. They might start to feel a little shaky, and that would give them evidence that, hey, I should eat this simple carbohydrate. We want something that's going to absorb quickly, and your book does recommend examples of that, enough lifesavers, 4 ounces of fruit juice, those kinds of things. So review those and see what would be recommended or what we would teach our patients to carry with them. We wouldn't want them carrying a ham sandwich. That's something that's going to take a long time to absorb, and we want those blood glucose levels to get up quickly. That's why a simple carbohydrate is really necessary. Sometimes they might need to eat a carbohydrate snack before exercising if 1 hour has passed since the last meal, or if their exercise is going to be really at a high level and high intensity. And, like I said, many of our patients have other problems, so we want to make sure blood pressure is under control, and we want to assess for any renal or cardiovascular disease. And, make sure that, their meds, say for instance, if they're taking for blood pressure or other cardiac meds, that during exercise they're not going to be dizzy or develop orthostatic hypotension, because we don't want any injuries to occur during their exercise routine. And like I said, just exercising just takes a little bit of common sense. We really need to look at each of our diabetics individually. Are these patients early in their disease, or have they had diabetes for many, many years? Obviously with peripheral neuropathies that have already developed, we would encourage non-bearing weight exercises, swimming, bicycling, or even arm exercises. Our concern is when some of these patients have neuropathies, maybe that the PDR, that retinopathies that I talked about earlier. You really worry about vigorous and really intense aerobic exercises because we don't want any additional hemorrhage to occur in the eye along with any retinal attachment. Okay, so those are just some other very important and key factors to think about when we encourage our patients to begin exercise. We want to encourage great exercise, but we also want to encourage and promote safety. So other serious complications do not occur. All right, another big topic that we really need to think about is sick day rules. Everyone gets sick. So what are these diabetics supposed to do if they're on oral hypoglycemic, medications, or if they're taking insulin? The same goes for our patients while they're in the hospital. Many times our patients are NPO because they're going down for some diagnostic that they need to be NPO for. Or maybe we have a patient who is supposed to get a morning dose of an oral anti-diabetic medication, and they become very nauseous and they vomit. What do you do as the nurse? You're quite concerned because maybe you did an AccuCheck and the blood sugar's up, so if they can't take anything orally, how are we going to get these medications into them? And if we as nurses have questions, you can understand why our patients with no medical background also have questions. What do I do when I'm sick? I caught the flu, or maybe I got a little food poisoning and I just can't keep anything down. I'm very, very nauseous. So these are things that, kind of come across the mind of our patients as well as us. So here are some key points that we really want to talk to our patients about. Some of the more common ailments they may get is like a cold, okay, or even maybe the 24-hour, 48-hour flu. Because when we're sick, even with just a cold, our blood sugars may rise. This is because of your body releasing hormones to fight infection, which in result increases blood sugar levels in the blood and makes it harder for insulin to lower blood sugar. So that's why we have to develop a plan and give our patient what we call sick day rules so that there's no problem with any complications such as DKI or HHNS. So it's really necessary that you would talk with your healthcare provider previously to develop this plan for sick day to help in controlling your blood sugar, preferably upon the diagnosis of diabetes. So your patients now develop a really bad cold, okay? They're very nauseous. They don't have an appetite. It's very important that you notify the healthcare provider of the illness upon onset. If you're just on oral diabetic medications, continue to take those, okay? Or if you're on insulin, continue to take those too, even if you're not eating a normal diet that you normally would ingest, okay? You still need to take your medications, okay? But while taking those medications, it's very important that you monitor your blood glucose every 4 hours. Your physician may even advise the diabetic to monitor every 2 hours and to kind of log those results in a journal so that when you call them back, if things still are not getting any better, you can give the physician all your previous, maybe every 2-hour glucose to kind of give him an idea of what he should tell you to do next. Drink plenty of sugar-free fluids to prevent dehydration. If you can keep them down anywhere from 8 to 12 ounces every hour while awake, that'll prevent you from getting dehydrated, okay? If you're checking your blood glucose and you notice that it's over 240 milligrams per deciliter, then it's really important that you check your urine for ketones, okay? So if by some chance you're showing moderate or high ketones in the urine, you probably should call your physician, all right? You would also call your physician if you're trying to keep down that ginger ale, you're trying to keep down that Diet Coke, but you just keep vomiting, and your nausea and vomiting are continuous and persistent. That's another reason you would call your physician, okay? Even if you've given maybe 2 doses of insulin or taken a couple doses of your oral diabetic medications and your blood glucose is still elevated, you surely want to give your physician a call. Obviously, your body's in a state of stress. Those counter-regulatory hormones are being released, and that's what's causing that increase in your blood glucose. This is in order to prevent you from going into DKA. Maybe you develop a UTI, maybe you develop some kind of infection, because as we're going to talk about those 2 emergencies, probably the most common reason why a person develops DKA is the fact that they have developed an infection. If your blood sugars are higher than 240 for more than 24 hours, and really if you're unable to tolerate any solid food, and if you're really sick more than 1 or 2 days, you really need to call the doctor, because we're trying to prevent these serious complications from happening. Because these patients that, too, if they have a fever, that's going to dehydrate them much quicker, especially if the temperature is around 100, 101 for more than 24 hours. That's also another factor that also presents a higher rate of dehydration, okay? So you definitely want to call your doctor. Really watch, too, when, a patient is sick. Monitor intake and output. I mean, they don't have to keep exact amounts, how much they take in, but just kind of jot down, oh, I had a glass of this, and I haven't urinated since this morning. Because when they're not urinating, that's also another sign that they're dehydrated, and just kind of get an idea of what the urine looks like. Is it very dark yellow, or is it is it just a normal color? Because that can also indicate signs of dehydration. Just rest. Don't put yourself in any stressful situation. If you're supposed to go to work, stay home and just take it easy, okay? For those that can't eat anything solid, see if they would like to eat a little bit of Jell-O or gelatin or some fruit juice. But I think the most important thing is to continue your medications and definitely monitor your blood glucose every 2 to 4 hours, depending on, you kind of get to know your body and how you're going to react when you do get ill. If your blood sugars are all over the place, I truly recommend that you monitor them every 2 hours, okay? And if they are continuously high, check for ketones in the urine, and if those are moderate to high, then it's time to call the doctor. Some of these people that maybe start off with a simple cold or the flu end up coming into the hospital, because we don't want DKA to happen with these patients, okay? So that's the really key points when we talk about sick days with our patients, okay? And this is very, very important information that we need to definitely convey or let our patients know, because they're going to get sick at one time or another, just like we get sick. And many of them think, oh my goodness, what am I supposed to do now? I can't keep anything down. I think if we're checking blood glucoses and making sure that there's no ketones in the urine, at least at a moderate or high level, the person should be okay, and hopefully will pretty much get over that. It's just the monitoring that's really, really important, okay? I want to talk a little bit about surgical management. And also about our patients who are diabetics that have to have some kind of surgical procedure. You know, where do we want to see that blood glucose? And really, what happens to the diabetic when they do have surgery? What are they more at risk for? But in regards to surgical management, transplantation of the pancreas, if it's successful, would definitely eliminate the need for insulin. But these patients who would receive a new pancreas would have to be on lifelong immunosuppressive drugs, and we always know that many of those, you know, have toxic side effects. There have been improved surgical techniques and newer anti-rejection medications for people that receive transplants. The 1-year survival rate for patients is above 95%, with more than 83% of patients remaining free of insulin injections and diet restrictions after 1 year. Pancreatic transplantation is performed in one of 3 ways: pancreas transplant alone, pancreas after a kidney, and a simultaneous pancreas and kidney transplant. Simultaneous pancreas and kidney transplant is the ideal procedure with patients who develop diabetes and have uremia, who have both insulin problems and renal problems. Most of the pancreatic transplants are from cadavers, donors, using a total pancreas still attached to the exit of the pancreatic duct. The patient who's receiving the pancreas, their old pancreas is left in place, and the donated pancreas is placed in the pelvis. And so the insulin's released by the pancreas, a graft is secreted into the bloodstream, and the new pancreas produces about 80 to 100 milliliters of fluid daily, which is diverted to either the bladder or the bowel. Okay? We always know that rejection is a big possibility of patients that have, you know, pancreatic transplants as well as kidney transplants. Okay? Long-term anti-rejection therapy increases a person's risk for, obviously, infection, cancer, and atherosclerosis. Okay? And when insulin drains into the systemic rather than the portal circulation, blood insulin levels rise and increase the risk for hypertension and macrovascular diseases. So, those are just some of the possibilities of the problems we see with our patients who have pancreatic transplants. Doesn't mean that it's going to happen to everyone, but these are things to realistically think about when we're doing one of these transplants. There's a lot of other serious complications after surgery: thrombosis, pancreatitis, anastomosis leak, and of course rejection. Okay. And so those are things that, you know, we pray that doesn't happen to our patients. And then, of course, once they're on their anti-rejection medications, we look for very serious side effects, such as toxicity to the kidneys, causing the patient to develop an increase in their creatinine levels, and of course noting that they're now having a decrease in urinary output. There's also islet cell transplantation, where islet cell transplantation eliminates the need for insulin and protects against the complications of diabetes. That's another possibility for our patients. I'm not going to ask you much on these. I just want to give you a little bit of an idea of what happens when our patients might be good candidates for a pancreas transplant, and that ideally many of our diabetics suffer from not only insulin problems but also kidney problems. That's why ideally it would be great if we could do pancreas as well as a kidney. Okay. Just a little information about our patients when they go to surgery, our diabetic patients when they go to surgery. Usually, this is a stressful situation, and there is a response to stress. Levels of catecholamines, cortisol, glucagon, and growth hormone increase, as does insulin resistance. So that's why our patients who are diabetics that go to surgery are really at risk post-op for infection, delayed wound healing, and fluid and electrolyte imbalances, and of course the problems of hypo and hyperglycemia, as well as the emergency of DKA. If a patient is just on oral anti-diabetic medications prior to their surgery, they'll withhold all those and just put patients on insulin, like a type 2 patient, type 2 diabetic, about 1 or 2 days before. They'll obviously be NPO, and they don't give any short-acting insulin unless they've had some kind of IV of glucose. There's certain target blood sugars that they want to hopefully achieve with the diabetic while he's under general anesthesia and he's in surgery. Usually they like to take the diabetics early in the day because, you know, the longer they're out on the floors. NPO, not sure if they've had an IV started. That's where we can see problems arise before they even get to the surgical unit. Okay. So what we want to see with our patients when they go to surgery, you know, as I said before, anesthesia and surgery can cause stress response to CRH and increased blood glucose. HHNS is a common complication. Stress suppresses insulin action and increases the risk for ketoacidosis and metabolic acidosis. So along with HHNS, our patients are much more at risk for DKA. And with that, we want to keep blood glucoses under control, because with hyperglycemia, guess what happens? We see those 3 Ps occur, especially polyuria, and with increased diuresis, the patients can have problems with their blood pressure, and some of them already have issues with hypertension, ischemic heart disease, and have had previous MI. And if these patients are long-term diabetics, sometimes there's been damage to the nerves controlling the heart because of sinus tachycardia, sinus bradycardia, or even postural hypotension. We worry with prolonged diuresis. The patients become dehydrated and hypovolemic, causing decreased perfusion to the kidneys, causing your patients to develop acute renal failure. They're more prone to paralytic ileus after OR. Pre-op, sometimes they will admit the patients a little bit earlier than their scheduled OR date, maybe 2 to 3 days. Obviously, they stop oral medications, like I said before, and put them on insulin to control their blood glucose. Even if they're on insulin, the insulin may be changed to more of a longer acting and intermediate acting. Pre-op, they like to keep the blood glucose below 200. Higher levels will cause neutrophil dysfunction and increase the risk of infection. So the response to, bacteria will be a little bit less because those neutrophils really start to dysfunction. Obviously, you have a patient who's had surgery. They're going to have post-op pain, and with pain is a stressor, so it increases CRH and causing the release of cortisol. And so giving opiates slow GI motility, and sometimes opiates can cause the older patient to become confused, cause hypotension, paralytic ileus, and even respiratory complications. So we want to be very cautious when we give opiates for pain. Not that we don't want to treat the pain, but we want to really watch our patients very closely. Inoperatively, they're going to have IV insulin, which the only type of insulin we can give IV is regular. Glucose and potassium, we like blood sugars about 120 to 200. Below 200 reduces the risk for infection. Many times they'll have to hang an IV of glucose, 5%, or give a bolus of 5 grams of glucose per hour to prevent hypoglycemia, ketosis, and protein breakdown. Want to keep the temperature in the room at a normal temperature. Might even monitor ABGs, because remember, with the 3 Ps, the outcome for that is metabolic acidosis. Post-op, we like to prevent hyperglycemia and keep blood sugars around 110, and monitor to avoid any hypotension, and really reduce the infection rate, because when we start seeing blood glucoses rise post-op, that really puts your patient at risk for developing a post-op infection. Obviously, assessing electrolytes, watching potassium levels and sodium levels and things like that. And our goal is to, prevent any glycosuria, dehydration, and impaired wound healing. Okay, so these patients really have to be watched very, very closely. Sometimes, if it's a surgery that the patient can't eat at, they might be NPO after surgery, and we might have to give them a little dextrose sub-Q every 6 hours. IV dextrose, and then insulin sub-Q. I'm sorry. Remember, glucose control is also affected by nausea and vomiting, anorexia, and GI problems. So even our type 2s may be on insulin for a couple days, especially if they're NPO. They might be on Q6 blood sugars, especially if they're not taking anything orally, due to the fact that they've got to let things kind of take its course. Okay, so that's basically where we want to see our patients intraoperatively and postoperatively, and just thinking about the increased risk for infection and decreased wound healing for our patients that are diabetic. So, and really watching electrolytes and blood pressures and things like that, and really monitoring kidney function too, because with hyperglycemia, we can see that polyuria develop, causing your patient to get much more dehydrated. So I hope that kind of gives you another sense of how we have to treat these diabetics just a little bit differently in the OR, and it makes the anesthesiologist have even a more difficult and challenging job to keep these blood glucoses and the electrolytes and their respiratory and cardiac status pretty stable. So they've got to really watch things a lot. They might even be drawing every half hour or every hour blood glucoses, particularly if the patient is in surgery for a while and under general anesthesia for a while, if it's a very complex and complicated surgery. So those are the things that we see occur with our diabetics in OR, and really trying to minimize post-op complications as we do with any patient, but it makes it a little bit more trickier when you have a patient with diabetes.